Greetings, respected judges and committee members. I'm Satyapriya Nandagopal, a fourth-year medical student from Gulf Medical University. Today, I will be presenting our research titled Maternal Determinants and Obstetric Outcomes Associated with Gestational Diabetes Mellitus in the UAE. So, I will walk you through the presentation in the following order, starting with introduction, followed by methodology, the results of our study, discussion, conclusion, and finally recommendations. Gestational diabetes mellitus, or GDM, is defined as glucose intolerance first recognized during pregnancy, usually in the second or third trimester. Globally, it affects about 16.5% of pregnancies, with the highest prevalence seen in the MENA region. In the UAE specifically, prevalence ranges from 7.6 to 24.9%. The condition is mainly caused by pregnancy-induced insulin resistance due to placental hormones. Why it matters? GDM is clinically important due to its impact on both the mother and baby. For mothers, it increases the risk of gestational hypertension, preeclampsia, preterm labor, and cesarean delivery. For the fetus, risks include macrosomia, respiratory distress syndrome, hypoglycemia, and long-term risk of type 2 diabetes. Key determinants include advanced maternal age, obesity, family history, and conditions like PCOS. The objectives of the study were to investigate the socio-demographic, medical, and obstetric factors associated with GDM in the UAE, to identify clinical predictors for early risk stratification, to explore the maternal and fetal outcomes, and to help inform targeted screening strategies. The study was an unmatched hospital-based case control study conducted at Tumbe University Hospital between March and October 2025. We included a total of 600 participants, 151 cases, and 449 controls. Data was collected using structured validated questionnaires and electronic medical records. Statistical analysis was performed using the SPSS version 29 software with significance set at p less than 0.05. So I'll be summarizing the key findings from our results. Table 1 shows the association between the socio-demographic characteristics between the cases and controls. So firstly, age showed a strong association where women aged 35 and above had a higher rate of developing GDM with a prevalence rate of 49%. When assessing the nationality, we found out that 70.2% of those from the Southeast Asian region had high risk of developing GDM. Now, we also assessed the association between medical and surgical history of the cases and controls. We found out that 11.9% of those who had a previous history of menstrual disorders had a higher risk of developing GDM. Similarly, 9.3% of our cases had a previous history of PCOS. We also found out that 20.5% of our cases had a history of high cholesterol disorder, and 19.2% of our cases had a previous history of thyroid disorders. This shows that there is a hormonal as well as a metabolic link to the development of GDM. We also found out that 32.5% of our cases had a history of iron deficiency anemia, and 29.1% of our cases had a previous history of renal disorders such as UTI, pyelonephritis, and kidney stones. We also did find out a significant association between the surgical history, but we do not have enough literature that supports this finding. Now, Table 3 shows the association between the family history and obstetric history between the cases and controls. We reported that 39.7% of our cases had a previous family history of diabetes, especially among first-degree relatives. Now, we also found out that 38.4% of our cases had a previous history of cesarean section. Table 4 now shows the maternal and fetal outcomes that are associated with GDM. So we found out the most common ones being fetal macrosomia, which is a known complication of GDM. 15.9% of our cases reported to have a history of fetal macrosomia. We also found out some other complications significant, such as a history of amniotic fluid abnormalities, history of placental abnormalities, and history of neonatal distress syndrome. Table 5 shows the logistical regression analysis. So those predictors that were significant after chi-square were adjusted for confounders. The strongest independent predictors of GDM were renal disorders, previous history of macrosomia. Other significant predictors included age above 35, history of iron deficiency anemia, and family history of diabetes. These findings highlight the importance of clinical history in identifying high-risk patients. So for discussion, our findings support existing literature and provide new insights. First, increasing maternal age is clearly associated with higher GDM risk due to metabolic changes. Second, the strong link with renal disorders suggests shared metabolic and inflammatory pathways. Third, previous macrosomia indicates persistent maternal metabolic dysfunction. Finally, iron deficiency anemia may contribute through oxidative stress affecting the glucose metabolism. So to conclude our presentation, GDM in the UAE is multifactorial. Age, renal history, and previous macrosomia are key drivers that has to be taken note, and conditions like PCOS and thyroid disorders also play a role, often alongside other metabolic factors. So for recommendations based on the findings of our study, we recommend targeted screening, especially early OGTT for high-risk women, enhanced antenatal care, particularly for those with anemia or menstrual disorders, and a multidisciplinary approach involving obstetrics, endocrinology, and nephrology. These are the references that are used in the study, including the ADA guidelines and multiple peer-reviewed articles. Thank you so much for your attention. Hope you have a nice day. Thank you.